Hello, everyone, and welcome to the American Indian and Alaska Native Behavioral Health webinar series. I'm Kate Trams, and today we have our director, Anna Helena Skinstad, presenting on women with substance use disorders. We sent out a notification. I wanted to just note at this point that we originally had another presentation planned, but due to illness of the presenter, we're going to have to reschedule that one. So the one that we had planned for colonization, we are planning to reschedule for 2016. So please look for our future publications about that, and we will be sure to let you know when that will happen. And thank you so much for joining us today for this presentation on women with substance use disorders. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more about the ATTC network, please visit our website. Coming up in January, we have a session on mental and behavioral health considerations for Native transgender people, led by Michaela Gray. And we are continuing to look for ideas on topics for this webinar series. So if you have an idea of a topic or a presenter, please let us know. My number is provided on the slide, and my email address as well. So please email me if you have an idea or would like to suggest a topic. We also have an essential substance abuse skills webinar series. Our next session in that series takes place on December 16, when Dee LeBeau-Hein will be presenting clinical evaluation treatment planning. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The request form is available for download in the files pod in the webinar screen, and will also be sent in a follow-up email to all who attended. Immediately following today's webinar, you'll be redirected to our GIPRA evaluation. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. If you prefer, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outward. To return to the regular view, click the button again. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. The opinions expressed in this presentation are those of the presenter and do not necessarily reflect the official position of CSAT, SAMHSA, or the U.S. Department of Health and Human Services. And today we have our director, and we're excited to have her share with you, since she has a great deal of experience working with women with substance use disorders. She's worked in both Norway and the U.S., and her commitment to human rights has grown stronger as she has expanded her work to include American Indian and Alaska Native treatment providers. So she's currently working across the country with these providers to enhance their skills in providing evidence-based and experience-based treatment, and with an eye on the fact that this population has a right by law to receive culturally informed behavioral treatment. So I'm excited to welcome our director, Anna Helena Skinstad, and I will pull up your presentation, and then we'll pass things over to you.
Thank you very, very much, Kate. As you said, substance abuse in women is my favorite topic to talk about. So I was very delighted to be asked to give a presentation today. It's a big field, and I want to all remind you that yes, we are in 2015, but we still are very much in the era where women with use of substances, abuse of substances are stigmatized. So I want to really address that a little bit. I want to talk about prevalence data, a little bit about etiology and prevention and treatment issues. And we will continue to talk about, or end by talking about, a couple of our women projects that we are very, very proud of. So when I say once upon a time, I don't want you to think that stigmatizing of women has ended, but it has evolved. So if you think about how this all started, treatment of substance use disorders often was burdened by stigmatization of women. And in the 30s, women were treated in mental health institutions because that was more acceptable for most women rather than being seen like a drunk. And then at that point, we thought that women and men were practically identical, so we could also provide the same kind of treatment for women as for men. And even in, as you can see, this reference in 1987 by my husband Peter and I indicate that a lot of substance abuse treatment at that point was hampered by the fact that not enough women were included in the research sample. That is changing, but I wouldn't think enough. And there are cultural differences, and Western Europe and the US have very similar ways of treating women, but if we think in treating women in cultural communities, we need to think a little bit more expansive. We also need to ask ourselves, what does our tribal communities think about women who drink too much? How is this woman we're working with, is she living traditionally? Is she living in a bicultural world? Or is she assimilated into the Western world? All those things would be important when we treat her, especially also how to understand her way of internalizing a stigmatized perception of her as a woman with disease like substance abuse. And the reason why I focus on culture is that if we go outside of tribal communities, there are very many similar ways of looking at women. And this is Talmud, is a Jewish code of conduct. And here you can see that it's okay to have one glass of wine. If you have more as a woman, it's demeaning. And then you get into the idea that women are immoral if they drink too much. And after 4 cups of wine, they lose self-respect and shame. So it's similar. And if you think in Arabic countries, drinking for women is really unacceptable. This also reflects in the way we have been treating women. And I already referred to generic treatment, which was similar for men and women. Later on, we focused on gender differences because we knew that there were biological, psychosocial, and physical issues that were different for men and women. And gender specific, if you look at some of the federal programs, they were very often focused on how to support providers in developing specific programs for women and men. Later on, we focused on trauma-informed, strength-based, and relational theory when we thought about how to develop a treatment program. And my suggestion is that we look beyond and we look at all the differences we have between men and women, but we need to introduce culturally informed treatment. I want to briefly remind all of you what it means to talk about moderate and heavy drinking for women. And oftentimes when we do this, we think about the standards that I am going to present to you as something that really is a little bit underestimated. However, when we talk about moderate and heavy drinking for women, we talk about it from the perspective that with increased drinking and consumption, there will be more and more serious medical, psychosocial, familial consequences, community consequences for women. So let us look at what the definitions are. And when it comes to binge drinking, we are looking at 4 or more drinks in one sitting. That is a binge for women. Men, it's more, but it's one sitting. And if you think about a client who is drinking, you will most likely say this is a very low number. Moderate drinking for women is between 4 and 9 drinks per week, not in a sitting. And heavy drinking for women is 10 or more drinks per week. And we measure this way. We call it alcohol equivalencies and drinking. And what that means is that it takes the same amount of time to metabolize these same amounts of alcohol that you see. A bottle of beer, a shot of whiskey or brandy, and a glass of wine will take half an hour to metabolize, and that's what we think about when we talk about alcohol equivalencies. When we look at prevalence of substance use disorders across the lifespan, there are different times when or age groups that have different substance use disorder issues. So if you look at early onset, which is before age 13, you will see that for both boys and girls, that increases their likelihood of later on reporting significant alcohol use disorders. The other thing that I want us to think about is that our grandmothers and our mothers may not have been drinking as much as you can see is not unusual in our younger women. And that being said, that the gender differences has decreased in recent years. And this is actually quite disconcerting because we know that with increasing consumption, and especially among women, there are more consequences than there used to be. And here you see differences between what predicts later dependence in boys and girls who start early drinking. One thing that I want to highlight is that the strongest predictor of chronicity and early onset in girls is sexual abuse in childhood. What we also need to think about is that when kids start drinking early, that influences physical development. And we know that there are a lot of physical changes, hormonal changes, neurological changes in adolescence. And one of the most important things is that the prefrontal cortex, where people are making decisions, where you are goal-oriented, that is really not developed in adolescence. And we sometimes think that that takes all the way up to 20, early 20, 25 to have that part of our brain develop completely, which means that adolescents aren't really able to make informed decisions. Parts of the brain called amygdala mediates emotional reaction and response to stress, and that is also under major development during adolescence, as well as hippocampus. What is very important also, especially with adolescent girls, is that some of the maturation that happens naturally in adolescence very often is associated with hormonal changes, and girls may find themselves being upset, feeling depressed, with low self-esteem, and that is part of maturation, but also may be affected by the alcohol use. And the interesting part is that girls who physically mature early are at risk for a lot of things. And that may result in experiences, traumatic experiences, that they may otherwise not have experienced. And girls tend to feel more stressed than boys, are more sensitive, and have lower tolerance to alcohol. And what is the important thing is that chronic alcohol and drug use in adolescence disrupt development of and changes in hormonal levels as they're growing up. If we look at lifespan issues and substance abuse, and we look at women in childbearing age, on the national average for moderate drinking is 15%. Heavy drinking is 5.5%. What I'm saying when I'm saying difficult to estimate level of drinking for women, it is because we are not necessarily having reliable data on drinking level in tribal communities, urban Indian communities, because there is differences in how many tribal communities, for instance, who share their data. And one thing that I really think is important in this is also to remember that a larger percentage of women in Native communities and Alaska Native communities are abstaining from alcohol. And that's sometimes forgotten when we look at how much people drink and how much women drink in general. Oftentimes, we then think about the heavy drinkers and also the abusive drinkers. If we look at worldwide, it's generally the case that men consume more alcohol. What we do know is that being married, living in a stable relationship with a partner, and growing older, in other words, maturing, oftentimes reduce people's drinking, both men and women. But depression in this stage of lifespan is predicting alcohol use. And also what we see is prevalence of up to 2% of illicit substance abuse in expecting mothers. Again, here it's difficult to get accurate numbers from tribal communities. When it comes to older women, our elders, women over 65 years, varies in national averages between 1 to 15%. But problem drinking is between 1 to 8%. What is something to be concerned about, and this goes for tribal communities, urban Indian communities, as well as the rest of the country, is in the rise of prescription drug use in older women. And what we also see is that even though there is a rise in prescription drug abuse, there may not be as much a rise in illicit drug abuse among older women, but for recreational reasons, but using prescription drugs for medical purposes, starting is often the beginning of a abuse pattern, and something to really look out for when we treat women over 65. What we also need to remember is that when we grow older, 65 years and older, we lose tolerance from alcohol. It means it decreases over age because we become more and more sensitive to alcohol. What that also means is that medication over the counter is also decreasing in tolerance. So older women may respond to over-the-counter drugs and prescription drugs in different ways than before they were 65. And the combination of alcohol and use of prescription drugs or over-the-counter drugs is risky for older women. What we need to remember is that older women, many of our physicians give easy benzodiazepine, barbiturates, antidepressants prescription, and painkillers for women. And that's something that we need to really be concerned about, especially benzodiazepines and barbiturates, because they can cause confusion, can cause psychotic breakthroughs in older women at a very low dose. And here are some of the risk levels. What I want to highlight here is that there are factors that really increases the likelihood of older women experiencing difficulties in daily living, and that is when there is use of alcohol. There is also an increase in depression. And the combination of antidepressants and alcohol use is very risky. But we are still in very great infancy when it comes to understanding the health consequences of different alcohol use patterns in women. And that goes for women in the US as well as women in tribal communities and from urban Indian communities. I also want to highlight sexual minority, lesbian and bisexual women. This is a group that oftentimes are forgotten and stigmatized. Lesbian women have a higher prevalence of mental health issues, may have experienced traumatic situations in childhood. Sexual orientation is associated with higher level of emotional stress. We know that lesbian women have more depression, phobias, post-traumatic stress disorders. They may consult their primary care physician more often about mental health issues, but they do not want to discuss their sexual orientation. And lesbian women also are at risk for suicide and suicide ideation, and women who are in the closet or are not out are more likely to actually attempt suicide. And the coming out process is very stressful and something that providers need to be very sensitive to when treated lesbian and bisexual women. Treating a woman, lesbian, bisexual, need to be open to addressing victimization and coming out and finding resources and supportive network, and think about their chosen family. Sometimes their biological family may not be as accepting. This may be different in tribal communities because tribal communities have a very much larger family network than members of the community outside of tribal land. It's very important to be sensitive to their privacy. It's not necessarily healthy to encourage women to be out in a treatment community because of other clients' attitude towards LGBT issues. What is very important if you are treating substance abuse and in lesbian and bisexual women is to be very sensitive and be prepared to train your staff in cultural sensitivity training, and also to train your staff in ensuring that the LGBT references that you use are affirming of homosexuality. I oftentimes like to look at this from a medicine wheel adapted perspective and think about the mental, spiritual, physical, and emotional health that is necessary to support for our lesbian and bisexual women, and think about the need for spirituality and support, and also the need for making sure that some of the physiological and biological needs are taken care of. Thinking also about minority stress. Sexual minority women have experienced oftentimes violence and chronic illness because it's shameful to go to the physician. And if you are a tribal member, if you are from the Native American community, you may have a double minority stress. I want to also address the issue of HIV/AIDS. If you look at this, the highest percentage of HIV acquisition comes through injection drug use. And as you can see, this is high for American Indian and Alaska Native. And the number of people diagnosed with HIV increased between 11 and 12, up to 20%. If you look at transmission, it's important to see that men who have sex with men is in the male population of American Indians, Alaska Native, MSMs are the most vulnerable for contracting HIV. And in men, it's less in heterosexual couples, and more in, if you look here, in MSMs using injection drugs. If you look at females from the American Indian, Alaska Native communities, transmission is majority in heterosexual communities, heterosexual relationships. So it's one of those things that really needs to be addressed in treatment. Sex, safe sex, do they know their HIV status? I also briefly want to touch on co-occurring disorders in women, and that means both mental health and substance abuse. And of course, we have already addressed that in most women there is a lot of polysubstance abuse. Illicit substance abuse would be increased in marijuana, stimulants, and opiates. And with the increase in prescription drug abuse, we have seen a drastic increase in heroin abuse in tribal communities. And of course, the co-occurrence of prescription drugs is what we have talked about earlier. Mental health disorders. Victimization of tribal women is very prevalent, unfortunately, and that often results in post-traumatic stress and anxiety disorders, especially phobic disorders. In addition, substance abuse often is co-occurring with depression, and those different bipolar or dysthymic disorders, in other words, swinging mood from uplifted to depressed state. What I also want to highlight is that we talk about telescopic development of substance use disorders in women. In other words, what we see is a more rapid development of substance dependence in women than men. And that may have something to do with the fact that women metabolize alcohol differently and achieve higher blood alcohol concentration over a shorter period of time than men. And because of these differences, there are more physical consequences. One of them is that women develop liver disorders quicker than men. Osteoporosis is developed quicker in women who abuse substances than women who don't. And certain cancers are more prevalent in women who abuse substances than women who don't. Also sometimes associated with smoking. And dental care is becoming more and more important when we treat substance use disorders, because dental care often is lacking in women, especially methamphetamine abusing women. And what you see is an increase in infections and a lowering of immune system with abuse of substances and reduce dental care. We also have a very clear concern about reproductive health and effect on menstrual cycle and experiencing of early menopause, and moderate use of alcohol has a positive effect on estrogen level in postmenopausal women, but it also affects the menstrual monthly cycle, and it also often results in early aging. We can't really forget fetal alcohol spectrum disorder. And as we know, working in Indian country, we know that certain tribal communities really have a very high rate of fetal alcohol spectrum disorders. And as you can see, the rate are as high as 1.5 to 2.5 per 1,000 live births. And what we are thinking about when it comes to what contributes to using alcohol while you're pregnant may have to do with feelings of being oppressed, loss of self-determination, trauma, poverty, and inadequate access to healthcare. And with the latter, sometimes that means lack of knowledge about the fact that drinking while you are pregnant is really very unsafe, and we actually do not think that any level is safe while you're pregnant. Let's look at etiology. What causes people to drink? And we have already said that American Indian and Alaska Native population have some of the highest prevalence of substance use dependence in the country. But there are regional and state and tribal differences. And sometimes there are communities that we sometimes refer to as drug infested, where there is a higher prevalence. And people in that community, of course, would be more vulnerable. And we also know that dysfunctional families, drinking in the family, domestic violence are community environmental factors that really has a negative impact on drinking in women. We also know that there might be genetic predispositions, but if we are very honest with ourselves, we don't know what that means for tribal women. The environmental factors that I think should remind us all as women that are important to think about is that mothers' drinking patterns are modeling for our daughters. So if we are excessively drinking, our daughters may think that that's the way it's supposed to be. If you see a very close relationship between an older sibling who drinks and use substances to a daughter, that means there is a higher risk for this daughter to also develop substance use disorder. We've talked about sexual and physical abuse as a very strong predictor for chronic and early onset. And one thing that I also want us to think about, and this is important research that is actually 30, 40 years old, and that is that when women change roles, when they lose a spouse, when they lose a job, their vulnerability for substance use increases. I often look to a very prominent lady called Edith Gomberg, who developed this model for what constitutes the beginning and the antecedents to substance use. And she was looking at it from different stages of a woman's life. And I'm not going to go through all this, but I just want you to look at some of them. And one thing I want to highlight, and very important during adolescence for girls, and that is, how did mom help and teach her to deal with menstrual cycle? Doing that in a healthy way is very important and a protective factor towards substance abuse in later life. The other thing is, how does the school, how does peer support, how does spiritual involvement in the family take place? Because I think spiritual involvement is very important. Connected to the culture is very important. So in tribal communities, that would be one of the things that I would really encourage as a protective factor for adolescent girls. Prevention. How can we prevent girls to start drinking, start using drugs? CASA is a very important center at Columbia University in New York City, and they have done a lot of research, and I do recommend that all of you familiarize yourself with that center. And if we look at sort of global models for prevention, we don't think that prevention that is supposed to be directed towards both men and women, girls and boys, will really work for women. What we think is that selective prevention program is what will work. And focusing on girls at high risk, victims of sexual and physical abuse, and indicator prevention programs, of course, is more like secondary prevention, where we are looking at how can we try to help girls who may start developing a problem and prevent them from having a full-blown substance abuse problem. We want to very, very much focus on pregnant women and the use of tobacco products, alcohol, and illicit drugs. And I want to highlight the visiting nurse program because that has very good effect. In fact, going to the home and helping is very important. Helping parents be better parents, because especially women feel that an important role in their life is to be a good mother, and how can we help her be a good and as good a mother as she can. And here again, collaborating with families and schools, very, very important. Engaging with the community is very important. And again, early intervention, prevention, we should really focus on women who have psychiatric disorders, who are using alcohol or tobacco. We should focus our prevention program on developing problem-solving skills, especially women, help them feel better about themselves, enhance their self-esteem. And a lot of programs and agencies, businesses have employee assistance program. I will talk a little bit more about that. That's a very good way of working on prevention. Women don't discuss their substance use disorders or problems with anybody. They will approach their physician, but in tribal communities, it would be very much more medicine men, women, clergy, or spiritual leaders. And we see in many tribal communities, as well as communities outside of tribal land, women using anonymous phone lines. And this again goes back to the issue of stigma and that women feel easily stigmatized. Early intervention is very important. And when we talk about early intervention, using motivational interviewing in primary care is less stigmatizing, and primary care is more acceptable for women, using a non-confrontational approach, using appropriate screening tools for women, give feedback and referrals, and be aware that older women prefer to go to their doctor rather than to a specialty care clinic. What I think also important is to use what we in public health call teachable moments. If you are working in a emergency care setting, in acute care clinics, you want to have the opportunity to talk about alcohol, drug abuse with victims of assault and domestic violence, women who have attempted suicide, and women who are depressed. Remember, we talked about home visiting nurse programs, and they are very effective, and it was tested with first-time moms, low-income moms who felt overwhelmed, and the first follow-up was within 2 years. Later on, it's been over several years, and what you saw was enhanced mothering skills. They felt more able to problem solve, reduce the mother's substance use, and it actually significantly reduced signs of depression in the children and also substance abuse in children over 12. I want to really highlight one program that is newly published, and we refer to it in our newsletter that was published earlier in the fall. And this is a early intervention program that use peer support, paraprofessionals, not visiting nurses, but adolescents who were mothers themselves and who were giving teen mothers and their children advice. And the tribes that were involved and the women that were involved had high rates of substance abuse, depression, were school dropouts, really had a problem with stable living, and felt very much out of control when it comes to parenting. The family spirit intervention was really giving these women very strong support, and the effect was very positive over time. There were 43 lessons delivered, and both teen moms and children showed positive results. They had few depressive symptoms, lesser use of substances, and the children in the intervention group was much more adjusted. So I recommend that you familiarize yourself with that. I also recommend that if you work in a community where there is a prevention program in an EAP, it's very important to know that for substance abusing women, going to an EAP program in your office is much more acceptable than going to a specialty care clinic. I will quickly go through assessment and highlight a few things. The main thing with assessment is to not be judgmental, to be gender sensitive, and to really focus on strength and understand that women are often raised to be for others. So they are thinking about others before themselves. So you may have to spend more time talking to her because she doesn't quite have a clear perception of what's good for her. I think it's very important to respect and support her dignity. Expect that you won't get information the first time you ask. Focus on co-occurring mental health disorder and be aware that she is very concerned about her children and dependent others. And there are some screening tools that are specifically developed for women, and TWEAK and TACE are two of them. And the Addiction Severity Index is also adapted for use in women and women from American Indian communities. Screening and brief intervention, important, but there are different assessment tools that are used. Treatment and behavioral health disorders. When you treat substance abuse in women, it's very important to understand that these are chronic diseases, that there are interactions between mental health and substance abuse. You need to focus on her feeling of shame, low self-esteem, and her victimization. Relapse prevention is very important. How can you identify with her the relapse triggers and the relapse situation that she's faced with? And changing lifestyle modification is very important. Having her feel that the whole staff has empathy for her situation and understand her need for support of her children as well. There are several psychosocial treatments, all of whom I'm sure you have heard about, that are evidence-based. And some of them are adopted culturally. We know that motivational interviewing is adapted to Northwestern tribal communities through the One Sky Center, and also to Southwestern tribes through the Navajo Nation. I also think that enhancing skills and working on relapse prevention is very important. And behavioral health therapy. All these things are evidence-based. Not all of them are culturally informed. The structure of a treatment, if it's an inpatient treatment, needs to focus on gender-specific programming. And if it's an outpatient setting, making sure that she has access to transportation and that she is surrounded by supportive family. I strongly support single gender group treatment and actually also single gender treatment programs. There are many different kinds of stages of change. We know what DiClemente has developed, but Brown was very clear that stages of change is different for women. Because she may have different levels of readiness for change when it comes to domestic violence, sexual risk behavior, substance abuse behavior, and emotional issues, and may be at different stages with this. And the multiple needs and pressures they feel need to be considered. And the immediacy of what she expresses to us, if she thinks that she cannot be in treatment because her children are not safe, it's not going to help us saying that, yes, that's not going to be very as important as you taking care of yourself. And the motivation to change is dependent on how well the provider is able to work with the women's immediate needs before she enters treatment. When it comes to working with women and Native women specifically, these are very important therapeutic strategies. You need to be very specific with assessment. You need to be very caring, be personalized in your approach. Make sure you have developed trust. And don't forget to instill hope. And actually target use of psychotherapeutic agents and counseling, as well as making sure that if they need medical and psychosocial treatments, those needs are met. They need a comprehensive approach, case management, and recovery-oriented care. I highly recommend use of the peer support specialists. And wellness, holistic consideration of mental health and physical health, worry about nutritional issues and exercise, and don't forget nicotine. Nicotine addiction should be part of any woman's treatment goals to quit, and use whatever means, both psychosocial treatment and medication-assisted treatment, to reach that goal. It's very important to think about cultural issues, spiritual needs, and engage, sometimes make sure she engages with spiritual leaders in her community, and work with partners and spouses. Nicotine dependence, there are evidence-based treatments for nicotine dependence, and there are also empirically supported treatment for use of medication with alcohol dependence, and we should never overlook the importance of this. And opiate dependence is more, we have more evidence-based when it comes to use of medication for opiate dependence than we have for methamphetamine and cocaine. But there are antidepressants used for cocaine that has shown evidence-based. I also would like you to go and look at the needs of women and some of the standards developing core competency for mental health and substance abuse service professionals. This is a publication I was involved in developing, and I think it was published around 2010. I know I'm running out of time, and I just wanted you to see that there are other SAMHSA publications that may be very useful for you when you are thinking about treatment of women. Our two new curricula that you might be interested in is a holistic approach to treatment of women that is adapted to northern plain tribes, called Healthy Women, Healthy Lives, and we're looking at more a holistic approach. And hand in hand is also a program where we look at women with co-occurring disorders. But I think I need to stop. I am sorry, we only have 2 minutes left. So I see we have one question. Can you repeat them for me, Kate?
Yes, so this, and I'll just remind everyone, if you do have questions, please type them into the Q&A pod. The field to type them in is at the bottom of that pod, and it's just to the right of the presentation. So we've got our first question here is from Taylor. I have found that the Seeking Safety Manual has been helpful in my work with women who are working on reducing their alcohol use. Do you know of other evidence-based manuals that may be helpful?
Of course, Seeking Safety is a very well-known program for use of treatment of PTSD and substance use disorders. I think Stephanie Covington's module is also promising, but it's not as evidence-based as I would say that Lisa Nojovic's seeking safety program is. It depends on the substance you want to work on, and for instance, the matrix model is adapted to Native women and is evidence-based, as well as motivational interviewing and also cognitive behavioral.
Great, thank you for that question. We have another question from Luther. Are there other sensitivity concerns when assessing and delivering treatment to pregnant women?
I think pregnant women will struggle really with guilt and concerns for their baby. And what we do know is that it's important to stop the use of substances as early as possible. So in that sense, it's very important not to play up and really, what should I say, activate the guilt and the shame. Yes, we know that there are certain stages of a pregnancy that can be more crucial, but my experience treating pregnant women is that the sooner we can get her to stop and do healthy living, the better. So in other words, make sure that any reference to shame and guilt is not enhanced, and make sure that she has the protection of the community if she is an outpatient, or if there is a possibility for protected living, would be my recommendation.
Great, thank you. Randy's asking about where you can find the two programs that you mentioned, the Healthy Women, Healthy Lives, and the Hand to Hand.
Let me tell you that those two programs are programs that we are training on before you can use them, because they are quite complicated. But we are going to be in the position of offering trainings for that come 2016. So if you're interested, please send me an email. We've had several questions about this later, and we are going to start planning a training so people can use them, and then work with us on looking at the outcomes of those two programs. They have been used in the Department of Correction and in treatment programs for substance use, and we have finished the cultural adaptation of one and almost both of them. So we are ready sometime in 2016. Thank you for asking.
It looks like that is all of our questions for today. So I just want to thank Dr. Skinstad for sharing her expertise in this area, and thank everyone for joining us. It's been a really great webinar. So with that, I'll just remind everyone that we will be sending out a follow-up email, which will include a link to the recording of this presentation, and it'll also include handouts of the presentation, the PowerPoint, and as well as a link to the survey in case you are not redirected at the end. Dr. Skinstad, did you have any final things you'd like to say before we close?
I would really say that I am delighted that we have had people hang in there with us for over an hour with a very, very intense amount of information. And good luck in your work with women. It's a challenging and very important work, because it both means treatment of her substance abuse issues and also providing primary prevention for her children if we are able to make her stop using substances. It's very important.
Wonderful.
Thank you.
Thank you so much. And with that, we will close out and hope you all have a good day. Thanks again.